Well, hello, everyone. This is Joyce Davis. I'm PennLive's Outreach and Opinion Editor, and we're bringing to you another editorial board meeting that we're making available and accessible to anyone who can tune into our social media channels. We're delighted to have members of our board here, and I really am excited to let our readers and our viewers, listeners know we have now two youth members of our editorial board. This will be their first time joining us. We have with us Sam Pimental and Arushi Dedya. Sam, do you want to say hello and tell them who you are?
Yes, I can. Thank you, Joyce, for that introduction. My name is Samuel Pimentel. I have written op-eds previously for PennLive, and I'm currently a student at Dickinson College, focusing and majoring in political science and economics. I'm absolutely thrilled to be here. I think this is a wonderful opportunity. I feel like this opportunity will lead me to be more involved in my local community and learn more about the ongoings in the state that I love, Pennsylvania. So thank you for having me.
Very good, Sam. And Sam is a former intern with the World Affairs Council and Penn Live. And Arushi, do you want to say a word or two?
Yes, thank you again for your introduction. My name's Arushi, and I go to Cumberland Valley High School, and I'm a current senior, and I'm currently the youth columnist for PennLive, and I am very excited to be here. So thank you again.
Okay, well, we are here again with several members of our editorial team board as well. Vinnie Portzline is, and I see Gloria Merrick has signed in, and Reverend Sandy Strauss. We will probably have some others joining us, but for now, I'm just going to turn it over to the Pennsylvania Pharmacists Association, and I think Jill Gingrich is going to actually kick things off for them. We're going to be talking about, I guess, the cost of drugs, how do you get them, or whatever the Pennsylvania Pharmacists Association thinks we need to know. So, Jill, you want to take it away?
I will. Joyce, thank you so much. And thank you to your editorial board for taking the time to meet with the Pennsylvania Pharmacists Association today. I'd like to introduce Victoria Elliott. She is the PA Pharmacists Association's CEO, and she has several members from her association with her here today, including her, I saw Diane pop on, her communication director, Diane Powell. They have a conference next week, RX Revolution, happening right here in our very own backyard here in Harrisburg. So they're going to be able to talk about the conference and the issues facing community pharmacies in our Commonwealth. So that's really what they're going to talk about today. I'm going to turn it right over to Victoria to introduce her team and then get this started.
Awesome. Thank you, Jill. Really appreciate it. Joyce, thanks for coordinating everything. Hope you were able to get some coverage of the protest going on yesterday. We're right across the street, so we heard it all throughout the afternoon.
I was there. I was there. So.
Yeah, they were here for quite a while yesterday. So it's my pleasure to be joining you. I just want to provide a few, if you'll allow me, introductory remarks, and then I will ask each of my team members to introduce themselves and where they're working. So we are a statewide, I think, Joyce, as you know, a statewide professional pharmacy association. Our members include pharmacists, student pharmacists, pharmacy technicians, and others working in the pharmacy arena. We are absolutely delighted to have your student participants today. Students are a large component of the organization and actually a thriving component. And so we're always excited when students can be a part of anything that we're doing. So we were founded in 1878. That makes PPA actually the premier, that is the first pharmacy association here in the Commonwealth with over 2,300 members, including 1,100 individual pharmacists working in various areas. So not just community pharmacy, both independent and chain, but health systems, ambulatory care, long-term care, specialty, the pharmaceutical industry, and more. As Jill mentioned, on February 14th to 16th, we'll be at the Hilton hosting our annual conference. And a primary theme running through the conference is the role that pharmacists and their teams occupy in the management of patient care. Many of the programs offered at the conference will showcase the opportunity now before us as pharmacists to be paid as mid-level providers, same as physician's assistants, for example. This is the first for pharmacy in Pennsylvania to have pharmacists recognized and be paid, in this case through Medicaid, for the value that we're bringing to the management of medication therapy, chronic diseases, and their ability to assess in their practice sites a patient's condition and provide recommendations or referrals when necessary for treatment. Our goal with this newly bestowed status is that every licensed pharmacist in Pennsylvania enrolls as a Medicaid provider. In the meantime, we're also identifying and showcasing those pharmacists and practice sites that are leveraging these opportunities whether as a Medicaid provider or through a collaborative agreement with a physician, to maximize patient care, ensure appropriate outcomes, reduce hospitalizations or rehospitalizations, and provide access points for constituents who may otherwise not be able to find a primary care physician, travel to a clinic or a hospital, or lack such essential services in their communities due to the increasing number of hospital consolidations and closures and the numbers of community pharmacies closing as well. Last year, Governor Shapiro signed Act 77 into law. This bill accomplished two main objectives: expanded the scope of immunization authority for pharmacists to include ordering and administering FDA-approved vaccines to those 5 years of age and older, and added the ability for pharmacists working in appropriately credentialed pharmacies to order RSV tests in addition to COVID, strep, and flu. Secondly, it added some reform to how pharmacy benefit managers may operate in Pennsylvania, including audit limitations, limitations on patient steering, network adequacy requirements, pharmacy services administrative organization registrations, and increased transparency. The passage of the bill represents some significant steps forward for pharmacy practice in Pennsylvania and progress towards pharmacists being able to practice at the top of their license, and hopefully improved enforcement for fair payment for prescriptions by commercial insurers. But our challenges still remain. The first is recognition of pharmacist providers by all payers, Medicaid, Medicare, and all commercial insurers. The second and perhaps more looming challenge that pharmacy community specifically has faced for years now is the inability for pharmacies in a community setting to be paid fairly and appropriately for not only the product they're dispensing, which they've already purchased, but the services they continue to provide the patients, regular customers, and anyone else walking in off the street. This is the only industry in healthcare, and I would argue in any profession, that goes without consistent fair payment for the time our pharmacists spend with patients, whether it's for counseling, testing, where permitted, referring and managing medication therapy, packaging, labeling, delivering, shipping, etc. Our goal with you today is to share with you some of the success stories that we're seeing where pharmacists are making an impact, being given the ability to practice at the top of their license, but also to discuss the barriers that continue to prevent access to pharmacist care because patients are being steered to PBM and owned pharmacies and or mail order, or pharmacies simply can't carry products for which they lose hundreds or thousands of dollars, or pharmacists cannot afford to provide services for which they're not currently being paid. So Joyce, that's the groundwork we want to lay. And at this point, what I'll do is have our group go around and let you know where they're working from, and then we can proceed with some questions. So let's just start with Darren, because he's first on my screen.
Hi, everyone. My name is Darren Mensch. I am an ambulatory care population health pharmacist within the Jefferson Health System outside of Philadelphia and Abington, Pennsylvania. My role is a little bit unique in that I am under the population health team, which includes nurse care coordinators, social work, behavioral health specialists, and my role within that division of population health is really to bring medication management, comprehensive medication management to patients. I also, as Vicki mentioned, practice under a collaborative practice agreement, which allows me in the state of Pennsylvania to adjust medications and follow along with patients to help in between, especially with their primary care visits, and serve as a great access point for those patients, focusing on medication adherence, medication access, especially getting medications covered for patients. So that's my role.
Thanks, Darren. Rick.
Good afternoon, and thank you for the opportunity for letting us speak with you. My name is Rick Sape. I'm the president of Value Drug Company. Value Drug Company is an independent pharmacy wholesaler based here in Pennsylvania in the Altoona area, and frankly represent a number of PPA members and independent pharmacies across the state and the Commonwealth. And our role, not only to help to distribute products to those pharmacies, is also to help to keep them in business and to maintain their businesses, and more importantly, be able to make sure that they can continue to service the patients that are out there. I'm also a pharmacist, and just to quickly mention, as Darren mentioned, MTM, which is medication therapy management and comprehensive medication reviews. That is essentially assisting patients as far as for understanding their medication and making sure that they have their medication so that they can be adherent, which is essentially having medication for the full 30 days of the month.
Right. Dan.
Good afternoon, and thanks for having me. Apologies for the raspy voice today. I work for I'm a pharmacist. I work for Geisinger in across Pennsylvania, and I serve as their system director for knowledge management, which means I oversee the professional training of all pharmacists and pharmacy technicians on staff at Geisinger, as well as overseeing their collaborative drug therapy management agreements that all pharmacists hold with the physicians in Geisinger, as well as now with the allowance for pharmacists to be recognized providers with Pennsylvania Medicaid, working on getting pharmacists credentialed with both Pennsylvania Medical Assistants and the managed care organizations that oversee them.
Thank you, Nicole.
Oh, my name is Nicole Hassan. I'm currently the Director of Pharmacy Strategy at Value Drug Company with Rick Sape. Pharmacist by trade. I actually came from the bench, so to speak, like we call it. So I was a pharmacist in charge at one of our local independent pharmacies here for several years. Saw firsthand some of the impact this has out there in the community. Most recently, I do lead up the strategy team at Value. A lot of that is helping our independent pharmacies out with ways to look at that non-dispensing type revenue, how they can survive with all those decreases in the reimbursements out there. A lot of that being surrounded by that Medicaid provider status that we've been working on here for about a year. So we've successfully done a lot of that here at our pharmacy internally here in Duncansville, Pennsylvania. And we're just trying to leverage that knowledge and help a lot of our community pharmacies be successful with that as well. So thanks for having us.
Thank you, Nicole. Last is Nishamini. So Nishamini will be facilitating a panel with all these wonderful people next week at conference to talk about some of these success stories they've had in their practices, but also ongoing challenges. So Nish?
Hi, Nish Kasbaker. I'm a Chief Pharmacy Officer for Penn Medicine in Philadelphia. I support the professional practice of what I consider my pharmacy enterprise, and that includes pharmacists, pharmacy technicians, pharmacy students across a variety of settings, including 7 hospitals, soon to be 7 hospitals, ambulatory care clinics, retail pharmacies, physician practices, and infusion centers. Thanks for having me.
Thank you, Nish. So at this point, I would kind of ask you, Joyce, does the group want to start, with some questions and, kind of dig into what these folks are doing?
Yeah, why don't we do it this way? I normally start off just to give them a chance to get their their brain cells working on this, but they know they can jump in anytime and ask questions, raise their hand, or just jump in. But I guess the first, I'm hearing good news. I'm hearing some good news. Things are moving in the right direction from the last time we spoke, right? So but I'm still hearing that concern about the PBMs, right? And about the role that they're playing. And am I hearing right in directing or trying to direct patients away from only to their controlled pharmacies? Is that what I'm hearing?
That's one of the challenges of many. I'm going to ask Rick to kind of lay that out as simply as he can for you, kind of where we stand, at least in Pennsylvania, after the passage of Act 77.
Yes, that was a great summary of it. Obviously, we had a number of pharmacies that closed last year, and we still have pharmacies that are closing, and whether it be in the inner cities or more populated areas, but also rurally as well. So as a result, there were a number of provisions that were put in the law, but that only affected frankly, the commercial space. So it didn't impact both Medicaid and also Medicare. So which that is a pretty significant component of the number of claims and prescriptions that are filled. So that is one challenge, as well as the act only impacted prescriptions that were as a part of plans or prescription coverage that was changed since the act went into effect, which was in January. So there's this tiered impact. And I'll say one other impact one other challenge besides the direct reimbursement is also I'll say, appeal process, for lack of a better way to put it. And we look to continue to work closer to the insurance department because that's really where we can bring forward issues that come about. And that process is just beginning to be opened up since the beginning of January. So we look forward to that process being opened up more and continuing to collaborate with them. So I think that there's essentially we look to continue movement and continue to increase the abilities for pharmacies to be paid fairly, as Vicky mentioned, but also obviously make sure that access, which is the most important piece, the access and care can be given to Pennsylvanians. So that's really the most important piece.
Yeah, you have shared with us before the numbers of that it's not just good for patients and for consumers, that the pressures on the independent pharmacies in particular were such that they couldn't stay in business. So I want to ask you, do you see this at least impacting that and making it a little bit easier to do business? And then I do want to ask you, with all the stuff we're hearing about Medicaid possibly being obliterated and all of this stuff going on in Washington, is that having any impact on you?
I think I'll take the first part of the question first, if you don't mind, which
Right.
is I think we've seen a little bit of, and I'll have Vicky jump in as well too. I think we've seen a little bit of the slowdown of the spigot per se. It's tightened a little bit as far as the number of pharmacies closing. I don't know that that means that the reimbursement pieces have changed. I think it's a matter of there's a little bit more of diversification, meaning some more pharmacies have been able to get some more patient care services, meaning counseling and reimbursement from that perspective. But I think that as we come out of the winter, you may start to see an uptick of some of those closures again from pressures that pharmacies are relaying to us. Sadly, we're working through that now, and I think that many of their partners are starting to as well, meaning other wholesalers or other folks that the banking industry, et cetera. I think you're starting to still see some of those conversations. From a Medicaid perspective, I think that it's a little bit too early to tell. I think we've all seen in the news some of the challenges and the fundings, and obviously there's a lot of pressure for every dollar that's out there, both federally and from the state. And I think at this point in time, we're pleased with the response that's happened from the state and the expansion of pharmacist services and being paid as a mid-level practitioner. The benefits there are obviously we can get more services to more patients, right? And keep them healthier. But we continue to watch and work with them as I think those federal dollars, as they may change, it may have an impact. And we're just continuing to work, and we try to work as closely as possible with DHS and Medicaid. But I don't know that honestly that they have those answers quite yet from the federal government yet.
Right, right. Yeah, things are so very much in flux. I mean, anytime any of the editorial board wants to chime in, please raise your hand or ask a question. But I do want to get a little bit clearer sense of, I mean, you say that you've been now allowed to serve as another level of practitioner, right? That brings you additional revenue. How much? I mean, how much has that made things better for you? What is it? Is it 10% more revenue, or what are you able to say?
I'll jump in initially, and then please any of my fellow friends can come in as well too. It's been a limited number that have been fully not only registered but credentialed. There's a pretty lengthy process to that, as well as you have to be. It's only within the scope of Medicaid or the MCOs. So there's 7 programs that manage the Medicaid program throughout the state. So you need to be credentialed or enrolled with DHS or Medicaid directly, and then contract and credential. So it is a lengthy process. So it's been limited as far as how much revenue is incoming at this point in time. So I would definitely not say a 10% increase. I would say in the single digits overall. Because it is definitely a slow uptick, and I think that there was some other comments that maybe.
Well, I think, yeah. So Rick and I work with a couple of folks on the call here pretty regularly with Medicaid to kind of navigate this opportunity, and some of the challenges that have cropped up as people venture into this or try to get credentialed. So I'd love to hear from them on kind of what their experience is to date. And again, I would agree it's probably in the single digits, but from your perspective, Dan and Nicole, what are you seeing?
Yeah, if you know, I'm happy to jump in. And so from from the health system perspective, Joyce and team, I mean, certainly the dollars that we're able to recoup, by by working with patients who have Medicaid or one of the MCOs as their provider, it's helpful, right? It's taken us from a practice that was typically $0 reimbursement to a smaller amount, but it certainly doesn't recoup the cost. And I speak to that from the perspective of, pharmacy sits in so many different buckets, right? We have these visions of who a pharmacist is, and that's only maybe the top layer of what they do. And so I speak from kind of our health system where we have probably close to 100 pharmacists that are embedded in physician clinics, that are embedded in telehealth services and don't engage in kind of that day-to-day interaction with patients from working the bench, right? These interactions are just a little bit different. So there's no necessarily revenue that comes along with that until this Medicaid change. So a lot of times where we run into that discussion of how can you help with physician shortages, how can you help with those pharmacists come into play there, and the next question tends to be, well, what's it going to cost us, right? Or how are you going to make those dollars back? And the truth is, the money that we're recouping from Medicaid still doesn't offset the cost of having a pharmacist embedded in a clinic or having a pharmacist embedded in a telehealth center. And so what Darren can speak to, and probably Nish as well, many of the things we rely on is the value added care that a pharmacist adds. It may cost you some money to have that pharmacist working for you, but if you've got a patient that has better control of their diabetes and doesn't progress to having eye issues, doesn't progress to having nerve issues, doesn't have lower extremity infections, you've saved not only the system, but you've also preserved the quality of life of that patient. If you start to look at some of the other conditions out there, so certainly the justification of the physician isn't going to rest solely in the dollars, but I'll tell you it helps, right? If you go from receiving nothing to receiving a few dollars, it helps. Our goal is to eventually be able to cover the cost of somebody fully with that direct payment. But for right now, that offset, especially in this value-based, kind of decision, helps balance the charts a little bit.
And I could just chime in from the community standpoint, a little bit of a different setting and setup scenario there. So this is pretty brand new to the community guys in the field. The infrastructure, the processes that need to be put in place that weren't previously already there. That's a significant hurdle that a lot of our guys are trying to work through. Health systems, they have their set patients. They're coming in for the other providers. That's where they are. It's kind of a catch-22 in the community setting is if we get our patients from the medications that they're coming in and filling with us. So if we're not capable of filling those medications, we're not capable of capturing that, population, which were so easy to access, so easily there. So it's kind of like, if we can't survive filling the medications and can't continue to do that, then we're losing our population base to be able to service them and offer a lot of those services. So that's the balance that we're trying to struggle with in the community setting. And like he said, unfortunately, the reimbursements don't always necessarily offset the losses and the costs for us to be able to provide those services. So it's a very difficult conversation sometimes to have with owners and pharmacists on the bench as to whether, benefits outweigh like what they're actually capable of outputting. So just from a community standpoint, a little bit of a different scenario there.
And Joyce, if I could add too, we're not. I don't want Nicole or I's comment to feel like we're saying that it's not enough, right? I mean, we are the glee, and the feeling that we have from being recognized is great, and we're so happy with what we have. Just saying that we're hoping for more, right? So we're going to take the win. We really love what that Medicaid has decided to partner with us and work with pharmacists to advance the health of Pennsylvania. But there's more to do, and we're ready to work with them to do more.
Okay.
Yeah, sorry.
Go ahead.
I was going to tag into that because I think at the end of the day, this has been a big move for us in this state, and we are very, very excited about the ability to be recognized as a provider and in this fashion. And I think there's tons of data that shows that if you interact with a pharmacist, that you can actually see patients are more adherent to their medications, and they actually do better long term because they have somebody to talk to about their symptomatic issues and things like that. So we're very happy with what's happened.
Very good. Well, we do have some questions from our editorial board. So Gloria's hand was up first. Go ahead, Gloria. Gloria is the executive director of El HAC, the Latino Hispanic Cultural Center here. You have to unmute, Gloria. Gloria, yeah.
Yeah, I'm the executive director of the Latino Hispanic American Community Center of the Greater Harrisburg region. We cover 3 counties. And I just have a couple of questions. And I know I've been one of those people who've gone to the pharmacist and said, what do you think about this? Or what's the best thing to take for this or for that? So I get that part of it. I was wondering if a couple of things went through my head. More specifically, what can we expect? How can we expect, how can we expect the role of a pharmacist to change? What will we see? What will be different for us when we go into a pharmacy? Will there be anything different other than us going in there and asking questions? How's that monitored? What can I expect to see as a customer? The second
It
thing
might be happier, Gloria. You might get a happier pharmacist.
Yeah, I know. I've already resorted to teledoc, and so I'm curious to see, how that all plays into this too. But and my second question is, how do you keep the pulse of pharmacy deserts and the avoidance of pharmacy deserts? I've done a lot of work with food insecurity and food deserts, and I've read also about pharmacy deserts. How do you track that? How do you keep Black and Latino communities? How do you take the pulse of where those deserts might be, and how do you try to close the gap on those inequities that we're seeing?
Tough questions. Who wants to start?
I'll attempt to start really quickly. So for the first part, I think it's twofold where your experience might look a little different. First is in the pharmacy itself, you may start to see more consultation areas, especially more dedication spaces for that, so that a pharmacist can sit down with you and have some of those dialogues, have more of that face-to-face. There's sometimes those interactions are just like what you said, right, Gloria, as far as for asking about something for your cough or something like that, right? And hopefully your pharmacist is walking you to the product, talking to you about it, explaining how to take it and the side effects, right? What to expect. Those are, I'll say, traditional actions. But then I think you may see more and more time that a pharmacist sits down with you in the pharmacy. And that typically that could be an appointment based, or it could be, ad hoc, depending upon your schedule and the pharmacist, how they are. So I think you'll start to see a little bit more of that. And you've probably already started to see more immunizations happening in the pharmacies that really broke through in COVID, but you'll definitely see some even more of the immunizations there. And so I don't take all the time. There's definitely some folks on the ambulatory care side. And so maybe Darren, can you maybe talk to in clinics, or Dan, when you go to your doctor's office, that might look a little different for you too, and maybe let some other folks talk.
Yeah, I can certainly comment and chime in on that. So as I mentioned, I'm an ambulatory care pharmacist, so I'm actually embedded in medical physician primary care offices within Jefferson Health. So it's rather new, and most of the time when I get referred for patients, they're always very confused as to why they're meeting with a pharmacist. But what I try to set out and do is really help with a lot of the education piece, especially around insulin new starts for patients, or continuous glucose monitors for patients with diabetes. So a lot of what we're doing as a pharmacy team is being that sort of go-between. As we know, with the primary care shortage, it usually takes a while to get in with the primary care. And then once you're also established with them, you might see them every 4 or 5 months, if you're lucky. So that in between visits via telemedicine, or even if patients want to come to the office, they're meeting with me. And so again, you're not adjusting and changing your medications every 6 months. It could be every week. It could be every 2 weeks, depending how we set it up as, a relationship with the patient and the pharmacist. So that's kind of our role and what we do. And that definitely looks a lot different. But I do feel like a lot of the health systems within Pennsylvania are starting to catch on and building out the program. Our program's actually doubled in size within the last 8 to 9 months as pharmacists bringing on board. And a lot of that is focused around population health and value-based care, which is not necessarily the billing piece with the Medicaid space, but a lot of our insurance companies are starting to pay for value. So what that means is they're paying us if we take better care of our patients from an outcome standpoint, reducing readmissions, improving medication adherence, improving kind of medication prescribing on the correct medications for the right patient, we get value-based payments for that. And that's really where our team is focused in on.
Karen, those inequities in care that Gloria was talking about, making sure that we can get in touch with the Latino, et cetera, other communities. I think that you've done some work in that space as well too. Maybe can you talk to that? And then Vicki, maybe from a PPCN and the social determinants of health, maybe talk through that too.
Yeah, absolutely. We, as I mentioned, we have the pleasure of working with social work as well. So we can work with the patients that are identified for the social determinant or social drivers of health. So we do a lot of work in that space, especially around patient assistance programs through the manufacturers, identifying there's a lot more patients that are in fact eligible for assistance that really have no idea that it exists. Traditionally a lot of physician offices might not be involved or have the capability to take that paperwork on and coordinate that care with those patients. So we do a lot of patient assistance programs, which gets high cost medications to the patients for free. Or there's also state programs that they might not be aware of, especially for our elderly population. That I'm always quite frankly surprised that a lot of my patients do in fact qualify for it, but just had no idea that it existed. So
that seems like a huge benefit to have
absolutely.
someone there that will walk someone through and actually be a guide and an advisor.
Right.
Wow.
Yeah, that's good to hear. So let me just to clarify, this is like I get sick, I can go to patient first, I can call teledoc, I can go to my doctor, or now I can go to my pharmacist, right? I mean, I'm lucky if the pharmacist could, if the pharmacy answers the phone. But if so how will that work then? The pharmacies will work on having doctor hours or something, or pharmacy hours, and then I mean, how do you envision that, or how is that working? Just curious. Like, I get sick, I can call the pharmacy and I can talk to the pharmacist now.
Gloria, that's a great question. And that is today, there are certain codes that are certain ways that we can interact with patients that are a part of the Medicaid program. And that's one of the hopes that we will continue to see movement into the true traditional commercial and also through the Medicare space as well too, to allow us to service even more, not only more customers and patients, but even more a wider berth of different things that we can communicate with. Today, it's a little bit more narrow, but we're continuing to work to make that a little bit wider. So it's not exactly what you just said, but we're working to get there and advocating for that.
The key, Gloria, is that this has now been made available for people on Medicaid. But for those of us who have normal insurance, like we don't have that benefit. We need to get it.
Yeah. All right. Well, good. And on closing the gaps, just real quick on pharmacy deserts and stuff like that. Are you doing research on that, and how can we ensure that we're keeping the pulse of that and closing the gap on those inequities that are out there? Because I have done some research, read about that, and there is a concern about the Latino Black communities and having pharmacy deserts.
Yeah, Gloria, if I could comment, just working in the city of Philadelphia, one of the things that, and I come from a hospital perspective, we check the pulse of our community by our admissions, right? So the healthier our community is, the less they're in our hospitals. And so what I've seen is just kind of an increase in community-based initiatives. So not just immunizations, but other things. We have a homeless clinic where we actually allow patients to just walk in, we treat them. We have providers on site. We have a lot of population health initiatives. We used to have a mobile mammogram van that went out into the community. And so, the intent is actually to make the community better. And so many community pharmacies, in addition to hospitals, actually focus on a number of these initiatives as well.
Okay, thank you. Actually, Philadelphia, Pennsylvania was one of the places that was cited as having one of the major problems with the Black and Latino community and access. So thank you.
All right. Well, let's bring Reverend Strauss. Reverend Strauss, you've had your hand up for a while.
Yes, I think I heard you say this does not apply to Medicare. Is that correct?
Not yet. They're
Yeah,
working
that's what
on
I
it.
thought. do you anticipate that that may change for Medicare? Um, right now, it depends on the drug plan that you have. I was forced off the plan I had, which allowed me to go to my local independent pharmacy and pay the same thing that I would elsewhere. But now I'm on a plan that says my preferred pharmacy is one of the big chains, and I've had really good experience with my local pharmacy and that they follow everything really well. They're good about counseling and all that, and it frustrates me that I'm now being told, well, you really need to go to this other pharmacy where the services just aren't up to par. Or at least I've not found that they've been up to par.
So I'm
So the
sorry.
question is Medicare going to be included in this real soon?
Yeah, so Medicare has some, I'll say, initial consultation and there's a few focused areas, such as driving your adherence on specific medications or to do what's called that comprehensive medication review that Darren mentioned before. So consider that almost like a brown bag. You bring all your medications in and pharmacists will talk with you about them. Those are about your medications. Those are the items that are covered underneath Medicare. They're also really included within Medicaid, and the Medicaid scope now is much wider than that. We hope to continue to expand that. There's a national push to identify pharmacists as providers. And hopefully hopefully that will pass in this year or next year. And as that happens, that would expand the ability for the Medicare coverage, right? So that would be fantastic. And then from a plan perspective, obviously, I'd love to hear your positive experiences in the pharmacy. That's awesome. We would hope that and love any commentary on that to obviously allow any pharmacy to be in any network, right? We want to make sure that we can provide services because sometimes those restrictive networks create these artificial deserts that Gloria was just talking about, right? Because you may now need to travel 20 miles. And 20 miles to you might be one thing. 20 miles to somebody in the city or 5 miles in the city is just the same type of desert. So those are things that concern us, and we talk about that regularly. And obviously, we'd love to advocate for that. And I saw Vicki came off of mute.
Yeah, just an observation. So, PPA represents pharmacists in any practice setting. And so, we've got a lot of counterparts obviously working in those big chains. Unfortunately, some of them are, work in an environment where they're subject to metrics, sometimes almost impossible to meet on a daily, weekly, monthly basis. And so sometimes it's more about volume than it is about, the interaction with the patient. That's not to say that they're not there trying to do that, or that's what they want to do. And I would suggest that there are some locations where that's actually happening and happening quite well. There's a Rite Aid near me where my folks in my neighborhood love the pharmacist there. He takes a really good care of them. So, I think that kind of depends on the pharmacist, the volume, maybe their manager, things like that. But what we have heard pretty consistently that there's a big difference. And so, when Rick, pointed out that this idea that, there's this, don't know what the decision making often is on they call it network adequacy. We get emails here pretty regularly. Just got one this week from a pharmacy that was not aware that they were being removed from the network, but his patients sure were aware and brought in the letter and said, "What's this all about?" So it creates this angst, frustration. The pharmacist left at the counter to defend a decision they had no knowledge of. And so it's kind of a game that gets played, unfortunately, in an effort to supposedly save that organization that the PBM is working on behalf some money. So it's kind of this, and we're always caught in the middle, unfortunately. But I was going to ask Nish, I don't put her on the spot, but Nish just recently completed a term as president of the American Society of Health System Pharmacists. And that organization, along with a lot of other national pharmacy groups, is talking pretty regularly about some of these changes. And many of them work very collaboratively around some collective pharmacy practice issues. So I'm just curious, Nish, from your perspective, what are you hearing at the national level about that Medicare question and provider status?
Yeah, we're hearing a lot of action by different states, and unfortunately, it's not all states. So every state is kind of managing this differently in terms of advocacy and provider status, and it's it's a little bit all over the place, but definitely seeing, you know, people moving in the right direction, as well as working across different pharmacy organizations to kind of advance this.
Well, I was just going to say, I don't live in what what would be considered a pharmacy desert. We have a Rite Aid that's about 2 blocks from where I live, but I changed pharmacies to the local pharmacy because this particular pharmacy is so poor. And it's really sad. And that may not be the case across the board, but I it would sometimes take, a day or two before I could even get a prescription filled. So,
Mm.
I started going to this local pharmacy, which has been wonderful, and they are serving this community very well from what I can tell.
Fantastic.
Well, we also have a question from Sam. Sam, go right ahead.
First, I want to say thank you all for coming here. And I actually want to bring up something that hasn't been addressed yet. Now, unfortunately, there is a shortage of pharmacies. There's more closing. What's also concerning is the shortage of pharmacists themselves. I mean, you have many pharmacists that don't even have a official pharmacist. They have to transfer or float between multiple pharmacies, especially you see that with CVS and the big chains of that nature. And as you mentioned, there's a student wing. And I'm curious, what steps are you taking to get more students involved in this field? Because if we continue to have a shortage, I'm just hoping that wouldn't put too much pressure on current pharmacists and lead it to be a more miserable job for those who are already involved. So I'm just wondering steps you're taking with young people to get them into this field.
Thank you, Sam. Great question.
That's a great
Sam, are
question.
you
I
interested in
appreciate
going to pharmacy school? I know a couple. I can possibly get you enrolled.
Unfortunately not. Unfortunately not.
Ah, good Lord. All right. Well, all right. Spread the word to your friends. That's the best we can go with. So, no, and please, I think, you know, Sam, I'm gonna offer this, and then I'll let everybody else because it's near and dear to my heart. I spent 15 years in higher ed for a pharmacy school here in Pennsylvania. Had the time of my life and set me up for a wonderful position that I'm in right now. Um, there was a survey that was done, and I don't know how many years ago it was, and it was asking pharmacists or students who had looked to go to pharmacy school and didn't go, why they didn't pursue. And one of the top answers was, well, I shadowed a pharmacist and they told me not to do it. And it was heart wrenching. It was like it really hurt to hear that because so many of us love this profession that we're in. So many of us are invested in the people that we take care of, no matter how many people we take care of, how many problems they have, what they bring to the table. We love doing what we do for them. And so I would, anybody who's kind of listening to what's going on here, you may run into a pharmacist on their worst day, and that's going to be the day that they say don't do this. But honestly, if you run into any pharmacist or any profession on their worst day and they say they're going to tell you don't do what I do. So if anybody's interested to do it, ask them on your best day, should I pursue this? And the answer is most likely going to be yes. This is a wonderful profession to get into. And so I think many of the things that dissuade individuals from applying for pharmacy school, I've also heard come from social media. You hit up TikTok, you hit up Instagram, you hit up, X, and there are more videos about what a miserable profession this is than there are about what a great profession it is. But the truth is, it's great for most people. The impact you can have, I'd encourage you to go out and look to APHA or ASHP, the American Pharmacists Association, the American Society of Health System Pharmacists, and look at some of the promotional videos that they've put together about what it should be to be a pharmacist. And you hear about individuals who are working in infusion centers side by side with patients who are on chemotherapy for cancer. And you're learning about how the pharmacist impacts their life, helps offset the nausea, the aches that they're having because of it. And so it starts at grassroots, right? It's parents, it's grandparents talking to kids and saying, have you considered this? It's kids talking to their local pharmacist and saying, on your best day, would you recommend I do this? And it's really just us being better advocates for our profession, because not only there's not only low numbers of pharmacists coming out of pharmacy schools, there's low enrollments in pharmacy schools, which means the next 5 to 10 years we're going to see a pharmacist desert, right? To apply that in where we're going to get people to be able to apply to work in our hospitals, to work in our local pharmacies, to work everywhere. So I think it's looking for the right information source and getting them out there and paying attention to organizations like APHA, ASHP, PPA, PSHP, PACDS, any of the advocacy programs that are out there to say, is this what I want to do? So we can put those students in touch with the pharmacists that'll really show them the light that this profession can shine on a population.
Yeah.
Dan, has the salary kept up with is the salary sufficient to lure young people? You know, they all think they want to be in charge right at the beginnings.
I hear you. I will say my personal opinion is I don't know many people who start out in pharmacy who struggle, right? Is it gonna be what most people think they're worth? Probably not, but we all have a pretty high perspective of ourselves. But I have yet to find an entry-level pharmacist say they're struggling to make ends meet.
Okay, very good.
Good to know. Good to
Nash,
know.
did you want to add something?
Yeah, I can tell you what we're doing from a national perspective. ASHP invested $3 million in a public PR campaign. What we did was we've had articles in the New York Times, ads in the Washington Post. We've done videos. Dan alluded to some of it. So if you go to the website, it's called we'reyourpharmacist.org. There are actually toolkits that pharmacists can download, and they can actually take it. I myself go to my high school. I'm a student of the Philadelphia School District. I take that toolkit to my high school, to my grade schools. We're finding that you need to look at these students young and early and tell them how wonderful it is to be a pharmacist. And so we've also talked to some guidance counselor organizations as well to talk about this as a profession. APHA had gone to mayors of cities and asked, different kind of legislators about why is it important to have a pharmacist in your community and what do they do for you? And so we're actually taking a lot of these stories and trying to get that back to that younger generation to kind of elicit interest in the profession.
Thank you. Thank you. Gloria, you had another question.
Yeah, Sam, that was a good question. Thanks for asking that. I didn't think this conversation was going to be as interesting. I'll be honest. Talking about pharmacists, I was like, oh, okay, I don't know a whole lot about that. But as I related to myself and my community, it's been very interesting. So thank you. But I also wanted to ask, how does this new role of the pharmacist, first of all, I'll go back to Sam's question. I think it'll make the pharmacist profession more attractive as we expand their role. So that's one thing. But how, I guess empty shelves comes to mind when I think of pharmacy. So how do you separate like the pharmacist from the pharmacy? And what impact can we expect to see in pharmacies as a result of this changing role? I ask that because when I go into the pharmacy, I tend to see a lot of empty shelves, probably people getting stuff on Amazon and this and that. Do you see this changing? Do you see us continue to see empty shelves or smaller pharmacies or one-stop shop pharmacies that mostly focus around pharmacy needs? Because I don't know about you guys, when I go to the store, I can hardly find anything in a pharmacy that I used to be able to find in a pharmacy. Are you paying attention to that? And how do you see a pharmacy changing from separating that out or having pharmacies become their own entity?
The pharmacy as a retailer.
Pharmacist, yeah, as a pharmacist role.
Is that on your agenda to try to make sure they have more goods to sell, more popcorn or something in there?
Or does that matter?
I'll attempt to jump in, and I can put the wholesaler light to this as well too. We see both. So we see pharmacies that are not necessarily what your most recent experiences are, right? So that they have a robust front end. And it may not be the front end that maybe that you recall from like the 1980s or 1990s, right? And I've worked in those. It may not be exactly that, but definitely a very robust front end with a vast variety of product. I think that what you're seeing in the pharmacies, both in an independent and in a chain environment, are secondary to some of the reimbursement pressures as well too, and cash flow, et cetera. Because the reimbursement has been so tight and been so restrictive, you see a reluctance to invest in that front end as much. And also, frankly, patients also at the same time may get those products for other avenues, like you mentioned, right? So I think you're seeing the confluence of both that happen. But I will say that just like any business, when it's run well and you see it, and you get patient churn in and you have the right people in the right places, you are seeing those thriving, I'll say, traditional pharmacies like what you're talking about. So we see both. Sadly, we see a little bit more of those lack of product on the shelves, and some of the even the bigger chains you see. I mean, what I'm saying is all public. You see their financial results, and I think that that's a part of this too.
That's interesting. Okay, thank you.
I wanted to give Darren a chance. Apparently, he can comment a little bit on efforts to recruit students into this field. Darren?
Yes, absolutely. So the last 2 or 3 years, I've been able to host the Eastern Regional Meeting on behalf of the Pennsylvania Pharmacists Association here in Philadelphia. We started with a Western Regional Meeting in Pittsburgh with John DeJames out there, who is now our PPA's president. So it's really been all focused on sort of non-traditional roles. So as many of you guys have probably heard of Chewy.com, they actually have veterinary pharmacists that work for Chewy. I didn't even realize that until we were kind of setting out the agenda. There's compounding pharmacists, there's pharmacists that work for pharmaceutical industry companies. So there's a lot of different options out there, that not just a pharmacist has to work behind the bench. I certainly, every time that I ever, when my grandma, I remember she always used to say, "Oh, Darren, he's a druggist that works behind the counter at CVS." And I would always laugh because nobody should be saying druggist these days. But either way, it was always that perception that pharmacists are only working within a retail pharmacy. So I think that has sort of changed a little bit, but certainly still needs to be a part of the conversation because I can do all of the wonderful things on the clinical side as a pharmacist working in a primary care office. But if the patient can't go to a pharmacy and get that medication, I just wasted all of my time there. So that's what a lot of my focus is making that link to make sure that there's not all that back and forth between the pharmacist and the physician, who quite honestly, the physician have no idea what the cost of medications are on 9 chances out of 10. So trying to bridge that gap is important. And again, if they're not getting to the pharmacy, getting the product in the hand, taking it, I wasted a lot of time in trying to make the most, perfect clinical suggestions.
Well, I want to thank you all we're coming to the end of our hour. I want to thank you for taking the time to explain something that's clearly a little complex. You guys are living it every day, but as we step into it, it's kind of hard to grasp our head around it. But the one thing I do know is that there seems to be some progress, but that progress needs to continue. And it's not just a question of keeping our pharmacists happy, but when pharmacists are happy, patients are happy. Just as we try to stand up for our physicians and our nurses, the team is important. And it seems like we're strengthening that medical team by strengthening the pharmacists. So I think I got that right. If I didn't, let someone correct me. Vicky, you want to have the last word?
I think you hit the nail on the head right there. The team, and the more we can really prop up our pharmacists who already have this knowledge and expertise, and get them in the right place with the right reimbursement, the better off everyone in the Commonwealth will be, for sure.
Well, very good. We will be certainly writing about this, and please do keep us posted on any further developments. We're glad to hear that Act 77 is now law, helping us all. But if anything else develops, please email or call and let us know. We'll bring you back in to talk about it.
Thank you so much. We really appreciate all of your time today.
Thank you. And thanks to our new editorial board members, our students, our young people. It's great to have you here, and look forward to our next editorial board meeting. Goodbye, everybody.
Thanks, everybody.
Thank you.